Welcome everyone. We are going to start the webinar. Welcome to this webinar is about intimate partner violence and pregnancy. We are going to start first introducing the panelists. My name is Azucena Ugarte. I'm the director of the Office of Domestic Violence Strategies, which is part of the Managing Director's Office for the Health and Human Services here at the City of Philadelphia. Asta, you want to go next?
Sure. Good afternoon, everybody. My name is Asta Mehta. I work in the Division of Maternal, Child, and Family Health at the Health Department here in Philadelphia. My role is I'm the medical officer for women's health, so I oversee a lot of our maternal morbidity and mortality programs. And I'll pass it over to you, Keisha.
Hi, good afternoon, everyone. My name is Keisha Montgomery. I also work in the Division of Maternal, Child, and Family Health, and my formal role is maternal health nurse manager, and I help coordinate, I coordinate the maternal mortality review committee, in addition to overseeing an IPV grant that we'll discuss today.
And Liz, could you introduce yourself, please? I know you're gonna be working with the questions and the technology, but you're also part of the team.
Hi, my name is Liz Pride. I'm the Senior Project Manager with the Office of Domestic Violence Strategies. I'll be monitoring the chat, so if you have any technical difficulties or questions, I will be keeping an eye on that.
So what we're going to do today, we have only an hour to talk about this very important and complex topic, but we already did welcoming and introductions. We're going to do a little bit of background about what intimate partner violence actually is, the definition of intimate partner violence, some national statistics around prevalence, and then we're going to go into Philadelphia and the statistics that we have for Philadelphia. And then over like a grant that Maternal, Child, and Family Health in collaboration with the Office of Domestic Violence Strategies have, we're going to describe the work that we've been doing there with community-based organizations and the delivery hospitals here in Philadelphia. And then go into a public health campaign that is part of that work and some next steps or ideas about what to do with that. And then we would open for questions and answers. So that's how the day is going to go. Well, the 55 minutes is going to go. Something that we always do when we talk about intimate partner violence and also about maternal mortality is to remind people to take care of themselves. This is a difficult topic. It's also, in the case of intimate partner violence, very common. So chances are that even people that come to a webinar or a professional training as a professional, chances are that 15, 20 minutes into the workshop or the webinar, they start thinking about, oh, now I understand what was happening to my neighbor, or now I understand what was happening to my cousin, or now what I understand what happened to my mom, and my mom never said anything. So even when you come as a professional, this is a topic that could become personal very quickly. So please take care of yourself during the presentation. And if at the end of the webinar, you feel still a little triggered about it, plan ahead what you're gonna do to take care of yourself during the rest of the day. So this is a disclaimer that we do with everybody, every audience. So let's start with the definition of intimate partner violence. This and something that we do in our work is try to be very clear about that intimate partner violence is not just a bad relationship, or it is not a relationship that is going through a very stressful situation and are trying to manage conflict and they cannot do it. Abusive relationships are very different than bad relationships or relationships that are going through difficult times. They may look very similar, but at the core, they're very different. And our response should be also very different. One way we like to explain this is that in a bad relationship or in a healthy relationship, you may have the two people arguing all the time, the two people maybe being aggressive at each other, maybe even physically aggressive, like fighting, breaking up, coming back. But it's the two of them, it's the two partners, and they have what we say equal power in the relationship. In the case of an abusive relationship, the dynamic is not the two of them having the equal power, but what we have is one partner having power and control over the other partner. And we're going to see there are different ways that the abusive partner gains and maintains that power and control. One way is, people usually know, the physical violence. So if my partner didn't do what I want them to do, I physically hurt them. Now they are scared of me. Next time I ask them to do something or stop doing something, they're going to obey me, because now they're scared of me and I'm gaining that power and control right there. But there are other ways, other types of abuse that abusive partners use to gain that power and control. But when we are working with people and with families and with couples, it's very important to try to understand, is this just a bad relationship or is this an abusive relationship? Because when we think, or when we are absolutely sure this is just a bad relationship, we can try to talk to the two of them at the same time. We can refer them to couple counseling or couple therapy together. That's an appropriate referral. But if we think somebody is abusing the other one, we have to be very careful about what conversations we have with the survivor and the person doing the abuse, what conversations we have separate, what conversations we have together. And we should not be referring for couple counseling or couple therapy, because a survivor or victim is not going to feel comfortable to share what is actually happening in the relationship if their abusive partner is sitting right next to them. And the abusive partner can actually use that space to further abuse the other person. One also of the main difference between a bad relationship and an abusive relationship, and how our response have to change, is that ending a relationship that is bad or conflictive, it's a safe option. Ending relationships are never easy, right? Even if you remember in your lifetime, maybe it was a bad relationship, you break up, it still didn't feel right, and then you get over it, right? But ending relationships are hard. But then the ending an abusive relationship is not that it's difficult, but it actually could be dangerous. Most victims of intimate partner homicides were killed after they had left, or when they were getting ready to leave. Because the abusive partner is not going to let you go. It's actually going to escalate the behavior to trying to regain that power and control. And that's very important for us to understand, because when we find out or hear that either a patient or a client, maybe somebody in our life, a family member, a friend, somebody we care for, when we hear that they're being abused in their relationship, usually the first advice we want to give is leave, break up, just be strong and leave. And we don't realize that we may be pushing that person into a more dangerous situation. Leaving is not that easy. And also leaving doesn't stop the abuse. The abusive partner not just going to let you go, it's going to try to find different ways to get back into your life. And one way, and this is important for our webinar, very relevant, is if you have a child together. Because that abusive partner, if they are the biological parent of that child, have rights over that child, and that's going to be the way that they're going to try to get back into the life of the survivor. So 3 things to remember about the definition of intimate partner violence. It's a pattern of behavior. It's not an isolated incident. It's not that a couple had a really bad fight because they were really stressed out about finances. It's not that. It's one partner looking for different ways to gain and maintain that power and control over the other one. Second, it's about power and control. Third, it's common in the sense that it could happen to anyone. It's not a matter of how much money, ethnicity or race, educational level, sexual orientation or gender identity. We see it everywhere and can be lethal. So people get hurt, children get hurt, the abusive partner sometimes also get hurt. So this is something that we need to pay attention. In the case of common, the relationship with common could happen to anyone. Also, it's happening more often than what we think. So when we're talking about that power and control, as I mentioned, there are different ways that abusive partners trying to maintain that power and control. I'm going to go just really quickly over these examples. But one is the physical abuse, which is actually physically hurting the pregnant person or threatening to hurt the pregnant person. But also could be not just physically hurting, but controlling their access to care. So controlling their access to the appointments, controlling their access with their medication. So that's one of the reasons why it's so important for us to know if this is happening, because your patient may be missing appointments, maybe not following up medications because the partner is interfering with that care. Sexual abuse, we consider sexual abuse when the partner or ex-partner forces you to perform any sexual act that you don't want to perform. That could be all the way to having intercourse and getting pregnant, or just public display of affection that you don't feel comfortable that this partner does in front of other people, but also controlling your access to reproductive health too. Emotional abuse is another one. One of the main things of emotional abuse is isolating the survivor or the partner from families, from friends, from the case manager, from services. So anything that could be a breach to the community, the abusive partner is trying to cut that. Put downs, blaming you from everything, denying your needs, gaslighting, other people call it crazy making, which is making you think that your perception of reality is wrong or is not real. So denying things that happen, or blaming that things happen because of your mental health. And in the case of pregnant people or postpartum people, it's like, well, I didn't do that. You think I did it, but it's because you are hormonal or whatever. You're overreacting. You just cannot control your mental health. It's you. The other part of the emotional abuse is the extreme jealousy. An abusive partner, and it's an excuse for the controlling. An abusive partner is going to accuse you of cheating because you didn't let me see your text messages, because you don't want to share your passwords with me. That means you are hiding something, or you were late, maybe because your healthcare appointment lasted longer, you had to wait longer, you come back home and the person doesn't believe you, accuse you of cheating. And what you have is maybe the survivor trying to change the behavior to prove that they are not cheating. So sharing the passwords, missing the appointments, or leaving the appointments so they can be on time at home to prove that they are not cheating. Another type of abuse is the financial abuse, which is controlling the finances, but also it could be sabotaging your work, your studies, sabotaging your childcare arrangements. So then you have to lose work or miss work because you have to take care of the children. And if you think during pregnancy and postpartum, when the pregnant person may not be able to work in the last few weeks of pregnancy or the first few weeks of postpartum, there's like this dependency on the other person for more resources. And then stalking, which is again a pattern of behavior that goes directed to a person, that causes that person feel afraid, fear, or be emotional distress. And this could be physically stalking, like showing up in the appointments, or also could be using technology and social media to follow that person and keep stalking them. Just really quickly about some data that we have at national level for pregnancy and intimate partner violence. Estimated 324,000 pregnant people experience intimate partner violence each year in the United States. Homicide is the leading cause of death during pregnancy and postpartum in the US, and most maternal homicides are committed by an intimate partner or a former intimate partner. And as in other places, we see some racial disparities. In the case of as all pregnant people, when the person gets pregnant, there's 60% increase of likelihood of homicide than when they were not pregnant. And this likelihood goes even higher, 39% in the case of non-Hispanic Black women in the US. Now I'm gonna pass it to Asta, who's gonna talk more about what we have here in Philadelphia.
Thank you, Azu. And as always, I always learn something whenever I hear you speak. So I appreciate that. It's just really a nice way to frame this topic. And so my goal here really is to share a little bit about, the prevalence here in Philadelphia and why we are so focused on working with Azu and her team around intimate partner violence and its connection to the work that we do at the health department. So we have a maternal mortality review committee, a local one in Philadelphia that's been around for about 13 years. And we review all deaths that occur to pregnant people during pregnancy and up to a year after the end of pregnancy. And that sort of encompasses this time period of what we call maternal mortality. We're really one of only a handful of local teams. So really, it's a privilege to be able to have local data to really inform, where we should put our efforts in terms of reducing this public health issue. The committee itself is multidisciplinary. We have people from all sort of backgrounds reviewing these cases that we see in Philadelphia to really come up with thoughtful recommendations from a systems level as to how we can improve outcomes for people during this time period. We have some data, and I'm going to share some data from our second report, which is from 2013 to 2018. Spoiler alert, we have new data coming out, hopefully in the next few months, and that can, updated data to inform, maybe some of the work that you all are doing. We'll go to the next slide. So this is kind of gives you a lay of the land, just in general. Now, these are all deaths that occur during pregnancy and up to a year after the end of pregnancy. And you can see that number has been somewhat stable since 2018. The blue line the blue in the bottom, that's looking at cases that the committee has deemed to be pregnancy related, meaning that the pregnancy or a chain of events from pregnancy led to the death. And so you can see that number has been pretty stable since 2011. Overall, though, that number is trending up, right? Like from that time period, you can see here in 2017, 2018. And I can tell you just as a preview that number has not slowed down. It is continuing to climb slowly, this like overall number of deaths that occur to people during this time period. And you can see homicide and suicide has been somewhat stable, but again, it's creeping up. And I'll just be upfront about that. And we'll go to the next slide. And so looking specifically why we're all here today is that intimate partner violence has been really shown to be associated with a lot of the deaths that we see in the committee. And so we know that these are sort of big picture items. We know that substance use, there's a big correlation with substance use and death during this time period. A history of mental health is also a big correlation. And then intimate partner violence, you can see, is also pretty well connected. And the reason that we're really focusing on intimate partner violence right now is that there's actually a lot of efforts being conducted across the city around substance use and mental health, but not so much in the space of intimate partner violence. And I think that sometimes people don't make that connection when they think about maternal mortality very broadly, but it's so important. And we know, from the data that Azu just presented, that there is a prevalence of IPV specifically in pregnancy. There's a specific need, time period that even more so, it's so important to really address these things because pregnant people are so much more at risk for bad things happening to them during this time. And so we know, and this is just numbers that we know, but we also know that the prevalence of IPV is very much underestimated in any way that we're able to gather data. And so this is just a baseline of what we know, but we're likely that number is much higher than 21%. We'll go to the next slide. Because of this, we took a little bit of a deeper dive into sort of, in general, prevalence of IPV in pregnancy in Philadelphia. And we used a data source called PRAMS, which is self-reported data. It's a specific data set where it's weighted particularly to kind of give you an idea of like what's going on with Philadelphians in general. And they people get sent surveys after their delivery and they answer surveys. And so this is where that data is coming from here. And you can see that approximately almost 10% of birthing people reported some sort of intimate partner violence during the perinatal period. And again, most likely, even though it's self-reported, I'm thinking people are still probably not being as honest about, answering that question, because it can, they're probably worried, like, who's going to see this, and all of those things. And we do know that in the birthing period as well, that psychological IPV is at its highest rate during pregnancy. And so potentially maybe not violence. And so I think, like, when we think about intimate partner violence, we're thinking that physical violence, but in reality, it's that other stuff that Azu was talking about, like the controllingness, and even I'm an OBGYN, and, I see these things a lot when I'm in the hospital, like dynamics among couples, and you're just like, that's something's a little off there if they're not letting, the person answer questions and sort of those types of things. And so it's so important for us as healthcare practitioners, particularly, to be in tune with like these types of dynamics, because it might not be that someone's coming in with broken bones or like wounds or, bruising, but it could be something else, but it's just as dangerous. And so it's really important for us as a healthcare field to have a better understanding of some of these signs. We'll go to the next slide. And so this can give you like an idea of like sort of who's most at risk for IPV. And this is based on our data. It's younger people who are more often Black and who are more often, less lower income bracket. They're reporting the highest rates of perinatal IPV. And we can see a big racial disparity in terms of Black versus white in terms of the prevalence of IPV, where Black birthing people are 4 times more likely than white birthing people. And so this just gives an idea of sort of the general lay of the land in terms of like who's at most risk. Not to say that we shouldn't be screening everybody, but it does give you an idea that, there are some certain risk levels that people face that others may not have as much of a risk. We'll go to the next slide. And so this is sort of again, ground level kind of like questionnaire where someone asks, did somebody in the healthcare field ask you if you about intimate partner violence or violence in pregnancy? And you can see like in pregnancy, really that number is somewhat high, but our goal is to get it at 100%. I think you're still missing a lot of people when you're not screening universally. As Azu said, it's insidious. It can happen to anybody, and it can have very, very big consequences. And so as we put it in perspective, when we think about that versus something medical, right? Everybody gets a blood pressure taken, right? Everybody gets some baseline blood work, but not everybody is being asked these really important health related questions. And that's kind of the work that we're moving towards, to be able to address all of these other things from a healthcare setting, because again, we're intimately involved in some of these dynamics, right? Like we see this like day in and day out in the office. We're seeing the same couple, potentially we're seeing them in the emergency room. So, we have this more sort of like vantage point of like really understanding dynamics over time. And so there's a very big opportunity for intervention that we sort of have that maybe someone that's just sort of like see someone once may not sort of pick up on. And so that's why like our goal through the city is to make that 100%. And we'll go to the next slide. And so based on sort of the data that I just presented, the conversations we have around the table when we review maternal mortality cases, a number of recommendations have bubbled up, so much so in the intimate partner violence space that it had its own sort of section in the report. And Azu has helped us write this section, so I'm going to give you credit for that, Azu. But there's specific things that we have called upon for different providers, different stakeholders to work on. And the first one is the one that we're really focused on right now, which is around implementing trainings for staff that work with pregnant and postpartum people around IPV screening, as well as what to do with the positive screen and how to do the screen effectively so people feel comfortable sharing. And then also being able to sort of do that next step of that warm handoff or that connection to experts that might be able to help that person in a longer term setting, outside of sort of the traditional four walls of the clinic or the hospital. And so that's what the work currently is focused on. And Keisha, I know, is going to go into a little bit of detail about that. But this is sort of the lens from which we are taking our marching orders. And it really comes from data comes from like conversations around the table with different stakeholders that are reviewing actual cases of maternal mortality. And we'll go to the next slide. And this is the framework from which we like sort of in general carry out some of the recommendations that come from our data, where we review cases, we make recommendations, and then those recommendations get translated into action through implementation teams. And so because we identified this as such an important issue, we were able to form an implementation team specifically around working on IPV and pregnancy. And that's the work that Keisha is going to outline next. And so I'll pass it over to you, Keisha.
Thank you, Asta, and thank you for providing that background. It's so important, so we know what the issue is, and we have the committee and that is able to provide these valuable recommendations. And I'll get into what we are doing and some of the interventions that we're working on. And so we were able to obtain a federal grant from the Office of Women's Health. It's a 5-year grant from October 2021 to 2026. We have $300,000 a year, and it's co-led by us, your hosts. So our division, and also Ajusana at the Office of Domestic Violence Strategies. And so this grant, it's a significant opportunity for us to make that lasting impact on IPV and supporting survivors. You can go to the next slide. So what are our project goals, and how do we plan to sort of implement this project? What are we doing? So 2 of our goals, the first one is to increase data collection on IPV and sexual violence in the MMRC process. So to enhance this process, last year we were able to collaborate with the city's DV agencies to discuss accessing records related to those cases. And so we were able to get records that provide valuable insights into those cases, specifically involving homicide. And so we get intervention opportunities. We learn the histories of those individuals affected by that intimate partner violence. And it helps the committee to provide actionable recommendations from the information that we're able to get. Our second goal is to increase delivery hospitals and ER's capacity to identify and respond to IPV. This goal really focuses on strengthening the capacity. The healthcare system is, as we know, overburdened, and there's a lot of shifting priorities, especially with COVID, and just all the things that they have to do on the daily. And so in the next few slides, I'll get into some interventions that we have put in place to sort of support the healthcare system and how we can help support them in identifying intimate partner violence survivors. So some of the strategies that we want to implement for this project. So what we've done so far, one of the things is develop an IPV implementation team. This is sort of a core component because this team helps guide us. So it helps support the project's interventions, and they really play a critical role in ensuring that the interventions that we come up with are well thought out and effective. And so that's the first thing we did in year 1. We are also developing a training for delivery hospitals. Some of the topics are listed. Well, the topics are listed here. There'll be about 5 modules, and I'll get into a little bit more about what that looks like in the future slides. Also, we are implementing a warm handoff system. Training and screening doesn't mean much if once we identify, we're not able to effectively support those survivors and say, here's a resource. We don't want to just say, hey, here's a resource, and then nothing happens. And so we're trying to bring this current city's DV services and the current city DV hotline together to sort of see how we can best bridge that gap from identification and providing those resources to make sure that they don't survivors don't fall through that gap. Because as we know, like once somebody reaches out for services, there's a very short, limited amount of time that we have to make that impact. So if someone says, hey, I need help, we want to be able to say, okay, here's what you can, here's who you can talk to, and here's an appointment. We want to make that sort of a seamless transition. And last, CHOP Policy Lab is conducting independent evaluation for our project. So their expertise will help measure the impact of these interventions that we're planning and help us improve and just ensure some transparency as we conduct these interventions. So who is on the IPV implementation team? So this team is made up of a group of dynamic representatives from the 5 delivery hospitals. We have all 4 of the city's IPV agencies. We have some researchers on the team, but very importantly, we have lived experience experts who are survivors of intimate partner violence. And so they help guide us, and they bravely share their stories, the barriers and some of the lessons they've learned from navigating some of the sectors on this team. And so they're able to share directly, and folks are able to hear from them. And so it's been very impactful. And thank you. So work done so far. So in year 2, like I said, we were able to meet with the city's DV agencies to get records. Like I said, this gives that committee insight so we can sort of drill down and get some more specific and actionable recommendations. Delivery hospitals created internal workflow teams. And so we are trying to enhance the current IPV screening practices within a healthcare system. And so internally, each hospital has their own workflow teams that they pull together. And what we do is meet with them monthly and help sort of guide them. We've done some trainings on evidence-based IPV screening tools. And so we've also helped to support create an IPV implementation guide. Like I said, there's always competing priorities, and we know what we're asking is, we don't want it to be a heavy lift. And so we've created a guide that helps them through screening, identification, documenting, and all of those questions that have sort of come up in our implementation group meetings. And we have also collaborated on the training. So we're developing a training, and Lutheran Settlement House is a DV agency that we're working with. So they are developing the content for that training for folks that will come in contact with perinatal people. Topics will include some of the foundational info that Azusana shared in the beginning. How to effectively screen using those evidence-based tools, what to do when somebody screens positive, what to do if you suspect someone may be suffering from IPV and not necessarily disclosing. Best practices for documentation will also be covered in the training, and facilitating a warm handoff. So Lutheran has been working super hard on the content to make sure that this is engaging. The modules themselves will feature like acted out scenarios, scripts, and so we want the learner to walk away with not just knowledge or, okay, this is just another box to check off, but how to screen with genuine intention. That was one of the things that the lived experience experts made clear. It doesn't mean anything if you say, oh, okay, you ask a question, but there's no intention, there's no genuine care behind that question. So it makes all the difference in getting survivors to actually speak up and feel comfortable to say what's going on. And next, I'll talk about the IPV and public awareness campaign. We have we've developed a first of its kind citywide campaign aimed at IPV and pregnancy. We want to bring awareness to the intersection of IPV and pregnancy. As we sort of stress, like, this is a very dangerous time, and homicide is the leading cause of death during pregnancy and postpartum in the US. So we want to, we're excited to share this campaign. It is already rolled out, and you may or may have not, hopefully you've seen some of the ads if you take public transportation. But I'll get into what the ads look like and what the intention is behind them. So we took sort of a two-pronged approach to the campaign. There is a public-facing portion for the community members with the bus and train ads. And there's also a medical-facing portion to support healthcare staff in identifying and screening survivors. So here you'll see some visual content. Your short walk to the daycare might be the only time they feel safe. And we wanted to make sure that this felt like a real life scenario. And, you know, we want folks to be comfortable in saying, okay, I have a friend who I might suspect is having some problems at home, or maybe they know about it for sure and just don't know what to do. And so that was the intention behind this campaign. And so whatever time they have to spend with that person, we want them to feel comfortable. That rare, brief one-on-one moment might be the only time they feel safe. Again, want to make sure that also family is aware. It can be difficult to know what to do, know what to say, know where to start, and providing support for someone who's suffering from IPV. And so here is the medical facing portion of the ads. So ACT, this is the acronym that we use: ask, connect, and tell. Ask if they feel safe, connect them to resources if they're ready, because they may not be ready to leave. This is, again, why our lived experience experts are so important, as they brought this to the forefront. People may not be ready to leave, even though you want them to. And just want to point out, protecting our pregnant and postpartum people is our priority. So just want to acknowledge that not all pregnant people identify as women. And so we wanted to ensure that gender inclusive language was used in this campaign to describe people who are pregnant. Thank you, Azu. Yes, that's still part of the public campaign. This is the medical facing portion, and with this you'll see we have palm cards and clinic posters that provide more specific information for screening under each acronym. Just recognizing that the providers have limited time with patients, and this information can help them maximize the time that they have and provide key points of what to say and do quickly. And so very soon, providers will be able to request these materials, the palm cards and clinic posters, via a link form that we'll share soon. And so I will pass it over to Azu to get into more of the acronym and how you can take action.
Thank you, Keisha. So this campaign, we really like it. As a domestic violence advocate, that idea of this moment could be the only time that the person feels safe. It's really, really, really highlights this idea of power and control and not just the physical abuse. And that's really important for us. So, and I think a lot of people in their general lives, as Keisha said, suspect that something is happening with my friend. I've seen it, right? And I don't know what to do, how to address it. So that's one for the general public. And then for medical providers, that one medical appointment may be really the only time that the person is not being controlled by the abusive partner. It's my one space that is just about me. So it's a great opportunity for the medical provider to ask the questions, to do the screening, and then to try to connect them with information. So in those two scenarios, we recommend the following actions, let's put it that way. So first, we need to ask. And in the case of general public, if you suspect something is happening with your friend, just ask informally, right? I notice, and you can say like, I noticed, it could be as bad as like, I noticed that bruise the other day. And when I asked you what happened, what you said didn't make that much sense. Are you safe in the relationship? Is there something you want to talk about? Or I noticed that every time we try to set a time to see each other, you don't say anything until you check with your partner first. Or I noticed that when we're just with a friend, the whole time you're texting back your partner and you're actually not having time with us. Can we talk about it? What is happening in your relationship? And it could be very informal, as in the case of healthcare providers, what we recommend, that there was a question in the chat, as much as possible to use an evidence-based tool to screen. We are also mindful that we're doing the screening not for research purposes, right? But we're doing it because we want to know what is happening so we can provide the support, because it affects the health of the pregnant postpartum person and the baby if there is a baby at some point. So we want to know what's happening because we want to help. It's not research-based. So we can be flexible with the screening tools, but as much as possible, an evidence-based screening tool, because it has been proved that it works, right? So we cannot just make up questions because they may not get information that we want to get. I know at some point, one of the questions I've been asked, like when going to medical appointments, are you safe at home? And home could be different things to different people, right? Safety could mean different things for different people. I can be like, yes, I'm safe at home because I have a roof, I have heating, I have electricity, it's fine. My problem is not my home, the problem is my relationship, right? So that's the advantage of using a screening tool that have gone through that. So it's really asking what we want to know. But we are also mindful that depending how busy your practice is, depending how time you actually have with the patient, you may not be able to ask 15 questions, right? To try to figure out the relationship. You may have to use 4 or 5, and there are screening tools that are really just 4 or 5 questions. And I wrote in the chat, the e-hits is one. There's the hits and there's the e-hits. The e-hits is extended, added a question about sexual violence. So that's, which is important. So you can do a formal screening. We recommend that you, before you start asking the question from the screening, that you actually introduce the screening, right? And there's language there. I ask all my patients about intimate partner violence or even violence in the relationship because it's common and it can affect your health and your baby. Now, this is my first question. It's so important to introduce it because then you're normalizing the question. You're asking everybody. The person doesn't feel defensive, like, do I look that I'm a survivor? Do I look that I'm the abuser? You're asking to everybody. So that's really important. And if you get a negative response, if the person says like, no, I'm fine, your friend says, no, I'm fine, what are you talking about? My relationship is great, love my partner. Like, okay, I just checking. If any moment you want to talk about anything, I'm here, right? Something also about the informal thing about ask, never ever badmouth the abusive partner. Because if you badmouth the abusive partner, chances are the abusive partner is telling your friend doesn't like me. And then to just justify that. So just focus on what your friend needs or your family member needs, not the other partner. In the case of healthcare providers, if you get no disclosure, no, things are great. Okay, thank you. If anything changes, you can let me know any moment. We have resources. Yeah. And also, depending on your practice, you may want to give resources for everybody, or have the resources available at your office, on the waiting room, in the bathroom. So if it's not safe, if it's not safe for the person to tell you for whatever reason, they can have access to those resources in other ways. Now, if there is disclosure, if the person says, yes, this is happening, this is where, in the case of healthcare providers, the connect means connect emotionally with them, right? No, do not like, oh, positive, okay, now you go there. But it's like, thank you so much for telling me. I'm sorry this is happening. I'm sure this is hard for you to talk about. That sounds scary, etc. This is not your fault. It's very important to send that message. You deserve to feel safe. Would you like to talk about some resources that I have? Would you like to talk to maybe the social worker? Would you like to talk to the behavioral health specialist that comes? In these days, like I can do a referral for you. So connect with them emotional so they can feel supported, and then transfer to specialized care. That would be the domestic violence hotline, if that's what they want. That could be the social worker, if you have one available, the behavioral health specialist, etc. Some things to remember that are very important. You may not have all the answers, and that's okay. Or you may have answers that the person doesn't want. So don't pressure them to do anything they're not ready to do. Follow their lead, give them options. Also, it's not in the slide, but don't feel that you have to fix the problem at the moment, at that exact moment. And I think that happens with a lot of healthcare providers and other service providers. There's a lot of anxiety about asking about intimate partner violence, because if the person says yes, now have to fix it. And you don't have to fix it. You won't fix it. Let's be very clear. You're just providing support at that moment and try to engage that person with services if they want. And this is one help that you provide in the process, sometimes long process, to get out of an abusive relationship. You're just one piece of that. And one of the biggest resources here in Philadelphia is the domestic violence hotline. You have the number right there. Also, all the materials from the public awareness campaign that Keisha mentioned, they take you to this landing page with also all the different resources in Philadelphia, and also National Domestic Violence Hotline, and very specific information that could also be useful for you as regular knowledge about intimate partner violence. And also in the Office of Domestic Violence Strategies webpage, you have also more information, not only for resources for intimate partner violence, but also resources for sexual violence and sex trafficking here in the city. And I think with that, we're going to stop here and we can open up for questions. And I know in the chat there was one question about, do we recommend evidence-based screening tool? As I mentioned, if it's possible, yes. What also I would say, and ask that you can jump in, is use a screening tool that also works for your place, right? You don't want a screening tool that is too cumbersome and then nobody does it. Right? It has to be something that works for you. And I think you may have to be very clear, like, not only is the screening tool, like these are the 3 questions we're going to ask, or the 5 questions, but who is going to do it? What platform we're going to use? If there is a no disclosure, what we do. If there's positive disclosure, then what we do. So it's not just about the screening tool, but the protocol that goes with that, how you're going to document that afterwards, being careful of confidentiality, and if the abusive partner has access to the medical records of the patient. So it's not just a screening tool, it's all the protocol around it and documentation. Well, thank you, Liz, for that reminder. Yeah, if there are any questions, please don't use personal information from a patient or something like that, because this is being recorded. Thanks, Liz.
I'm going to ask a question because I'm anticipating that some people are wondering where they could get those really great materials for their own practices or offices. And I know you mentioned that there will be a link that's available later on. Do you know where people would be able to find that link when it becomes available?
Yeah, so we'll likely host the link on our Birth Justice Philly website. And providers will be able to click that link, request the materials that they like, and we'll get them shipped out.
And we can put that website in the chat for you, so you can go there.
And I think it's related to that. There's a question that says, can other agencies that work with perinatal clients also have access to that information?
Yeah, like the campaign materials, absolutely. Like we're willing to send them to anywhere. Yeah, anywhere where you potentially find them useful for the clients you serve.
Thank you, Liz, for putting the website there. If there are no other questions, we don't need to keep people for extra time. I'm sure everybody's very busy. This is being recorded also, so that's something that we can share with everybody who participated, and they can share with their staff, co-workers that maybe will not be able to attend today. Liz, anything else that you think we should share or say?
No, so I'm just seeing in the Q&A, someone said, very helpful knowing that asking doesn't mean that we need to have the solution, which is very important to remember. But once this webinar recording is available online, you'll get an email probably at least in a week with that. If you have other colleagues or contacts that you think should really watch, a little 50 minutes on intimate partner violence and pregnancy resources in Philadelphia, that'll be available to watch later on too.
Okay. So, and if anybody wants any resources related to this, please reach out. Our contact information will be in that email, so feel free to reach out any of our offices and we respond. Okay. So thank you, everyone. Enjoy the rest of your day.